and welcome to another episode of Vital Times, the podcast from the California Society of Anesthesiologists. My name is Ron George. I'm an anesthesiologist at UCSF, and I'll be your host for this episode. Today's guest is a friend, mentor, and fellow obstetric anesthesiologist, and a highly engaged member of the California Society of Anesthesiologists. Today, I have the pleasure of speaking with Dr. Brendan Carvalho from Stanford. Dr. Carvalho is a professor and chief of the Division of Obstetric Anesthesia and the vice chair for faculty development at Stanford University School of Medicine. He is a past president of SOAP, the Society of Obstetric Anesthesia and Perinatology, and during his tenure on this executive, he started the development for the Foundation for the SOAP Centers of Excellence designation. This was created to recognize institutions that demonstrate excellence in obstetric anesthesia care and to set a benchmark of expected care to improve standards nationally and internationally. During this episode of Vital Times, the podcast from the California Society of Anesthesiologists, Dr. Carvalho is going to share with you how the SOAP Centers of Excellence came to be and what his vision is for its future. So Brendan, welcome to the podcast.
Hello, it's an absolute pleasure to be part of this podcast.
To get things started, I'm wondering if you'd mind briefly giving us a little bit of a history of yourself. How did you come about working at Stanford, being president of SOAP, and finally vice chair of faculty development?
Well, I'll start off by saying there was absolutely no master plan. Very much I was open to opportunities. I guess a lot of hard work and a great deal of luck. I was actually born in South Africa and did my medical training there. I then went to the United Kingdom and after a bit of meandering, specialized in anesthesiology there. One unique aspect of the training in the UK was to allow you to spend a year getting outside experience. And I used that to come to Stanford to do an obstetric anesthesia fellowship. And I've stayed on, and that was 21 years ago. I took over as chief of the Obstetric Anesthesia Division around 9 years ago, and it's been extremely rewarding. We're certainly one of the best, if not the best, obstetric anesthesia division in the world, and that's because of contributions of all of our faculty within this division. So when our new chair, Brian Bateman, offered the vice chair faculty development to me and the opportunity to influence faculty's lives beyond just the obstetric anesthesia division, it was certainly an opportunity I took with both hands. And so it's really exciting that I now have this role in addition to my division chief role.
Wonderful. So we'll just jump right into this, Brendan. So maternal mortality and severe maternal morbidity, particularly amongst women of color, has been increasing in the United States. What role can anesthesiologists play in the efforts to reduce maternal mortality and improve the health of people giving birth?
So this is an extremely important question, and it's very concerning, the high maternal mortality rates in the US compared to other developed countries. If you look at the leading causes of maternal mortality, cardiovascular disease is by far the leading cause. And then other important causes like hemorrhage, sepsis, or hypertensive disease of pregnancy. If you look at these top contributors towards maternal mortality, these are all within our skill sets as anesthesiologists to treat. We are trained to understand hemodynamics, manage hemorrhage, sepsis, and control blood pressure. So we must leverage our skill set towards helping deal with these important contributors towards maternal mortality. And as our contribution towards maternal mortality in terms of purely anesthesiology, we have become a minor contributor towards maternal mortality. So we need to leverage our skill sets to other more important causes. And while we do focus on mortality, for every one mortality is approximately 200 severe maternal morbidity, of which hemorrhage leads that cause. And it's extremely important that we use our skill set again to not only reduce mortality, but morbidity. Now, one of our limitations as anesthesiologists is we're only there during the hospital stay. So for us to have a bigger influence, we have to, like I mentioned, go beyond just providing anesthesia and become more perioperative physicians, both treating maternal conditions that contribute towards morbidity and mortality, but also going beyond our role both pre-operatively and post-operatively, impacting patients by improving pre-optimization prior to arrival in the hospital, and then continuing our care beyond the hospital stay. You mentioned differences in both racial and ethnic differences in maternal mortality, and this is striking, and it's been well described, and we really have to try our best to try and make an impact there. And we can do little things from improving access and removing barriers for language, especially in patients who are non-English speaking. We can hire better in terms of who we hire. Having a diverse workforce is very important. We can educate both our patients as well as providers with implicit bias training. And obviously be upstanders if you see any discrimination at the workplace. Speak up against that. You mentioned the role of anesthesiologists, but I also want to extend that role to the role of obstetric anesthesiologist and the subspecialty training. And I truly feel strongly that we can make a big difference by specializing in this area. And there's fairly good examples where obstetric anesthesiologists compared to generalists can make an impact in the obstetric care. Examples of that, and well demonstrated, is you'll reduce the number of unnecessary general anesthesia cases for cesarean delivery, and this clearly has the ability to improve obstetric care. There is more likely the utilization of different neuroaxial techniques for labor, and more likely to extend beyond anesthesia as a perioperative physician, dealing with nuances that are different in pregnant patients, both managing hemorrhage and changes in blood pressure. So our impact goes beyond just providing anesthesia, and especially in obstetric anesthesia, being perioperative physicians.
Great. Well, it leads right into the next question. So in 2015, the American College of Obstetricians and Gynecologists published the levels of maternal care. And in their efforts to reduce maternal morbidity and mortality by encouraging the growth of systems for the provision of risk-appropriate care specific to maternal health needs. And as you said, obstetric anesthesiologists and anesthesiologists have a skill set that can be very necessary to help improve this care and identifying some of these risks. Now, was it ACOG's development of the maternal levels of care, was that the impetus for the development of the SOAP Centers of Excellence? And how did this come about?
So it actually wasn't the impetus for developing this. Got more inspiration from Payne, where they developed Centers of Excellence recognition. But they linked pretty well once we developed SOAP Centers of Excellence. So as you mentioned, ACOG levels of care was essentially an effort to try and match patients, both maternal as well as neonatal, with appropriate care at the hospitals. In other words, if you have a low-risk, uncomplicated singleton term delivery, it would be okay to deliver at a level 1 basic institution. But if you have a higher risk pregnancy, you would want to be seeking care at the level 3 or 4 subspecialty or regional high-risk cares that can deal with complex, difficult patients, and they have ability to provide intensive care support and others that may be required. So ACOG came up with very clear definitions and guidance for both ante, intra, and postpartum care. SOAP Centers of Excellence is very different. ACOG really felt like they wanted to do a risk-appropriate care, and in doing so, push up the base and provide appropriate strategies for all patients. SOAP Centers of Excellence essentially was an initiative to reward centers that provide excellence in care. And as you mentioned, it could also provide a blueprint or a benchmark for centers to strive towards this as we defined excellence of obstetric care. And there were a few other benefits we were hoping we could obtain with SOAP Centers of Excellence. We would be able to create a sort of standard or what would be viewed as optimal care nationally. It could be a surrogate marker for excellence in obstetric anesthesia care or a quality metric. We wanted to promote our subspecialty of obstetric anesthesia. And so all of this was the impetus behind SOAP Centers of Excellence. But along the way, it was clear that we were going to, once this was better defined, use it to define level 3 or 4 centers. So the hope is that rather than how ACOG has defined the anesthesia care that it needs to be provided, we would define it by you need to be a SOAP Centers of Excellence to be a level 4 center. I mean, currently it's very limited what ACOG has defined as necessary for anesthesia providers. For level 4, it's just board certified anesthesiologists with obstetric anesthesia fellowship training or experience being present and with a lead with that experience to be part of the program. And clearly there's way more than that to provide excellent in obstetric anesthesia care. So this is more comprehensive evaluation of a program. So we hope that the two can coexist. And as we discuss more, I'll sort of give you some ideas for where we will go in the future to try and marry ACOG's levels of care and SOAP Centers of Excellence better.
Great. So how does one become a center of excellence, and what does it mean for an institution like UCSF, where I work, to be a SOAP Centers of Excellence?
So I think it certainly is something that means a lot, and I can speak from personal experience. When we got designation, it meant a lot to us. It's difficult showing excellence in different metrics. Obviously, core missions of any academic institution is clinical care, education, and research or scholarship. And you clearly have metrics for the latter two, but to show excellence in clinical care is certainly more difficult. So it allowed us to demonstrate that. And we certainly got recognition and prestige within our university and department and beyond. And nationally, it's something that we're proud of having this designation, as I'm sure you are at UCSF. I think in terms of what it means to an institution, it starts probably before you even get the designation, which is you're given a blueprint to what is expected to provide excellence in care. And then you have to essentially work on improving your practice to get this designation. So we had to, at Stanford, make changes. And so it meant a lot that we were able to provide the criteria that was necessary to get that. Once you get designation, different institutions have used it for a number of different purposes. Essentially, marketing has definitely benefited from this, both getting trainees or faculty interested, and also for patients being able to deliver at a center of excellence. There's potential cost improvements, so you can get better negotiations with your payers by providing excellence or demonstrating that you provide it, and potential risk management reductions. So it certainly means a lot to a lot of centers. Now, you asked, how do you become a SOAP Center of Excellence? Well, the first thing you have to do is you need to go to the Society of Obstetric Anesthesia and Perinatology website. And hopefully in the summary of this podcast, we will be able to provide the URL and go and read what it's about. On the website, we have the application form that outlines all the metrics and criteria that are required. It goes through the review process. It's an annual application. You get peer reviewed. You get asked to then give input. And then after a very extensive process, you will get designated the SOAP Center of Excellence designation, which is a 4-year award, which then requires recertification at the end of that. And if you're not successful, you're getting really valuable peer review input into your program. And we've had a number of centers that have used that feedback to improve their institutional care and then got designation on the following year's application. The SOAP Center of Excellence does not visit institutions, so we rely on honest reporting of the care that you provide. So I think that's really important. So SOAP Center of Excellence essentially is a document that outlines some metrics and then criteria that we view as important. It was developed by experts in the field. It's a live document, living document. It changes every year. We add criteria and modify others. The metrics we currently collect is a general anesthetic rate, ideally less than 5%, but the importance being that it is being recorded and all unnecessary general anesthetics are being reviewed and improvements made. We look at unintended wet taps or dural punctures, and with the aim of trying to have it at less than 2%. And then failed blocks, epidural blocks during labor to keep that somewhere between 3 and 6%. More important that you're actually recording this and reviewing failed blocks and trying to improve care as you can. And the criteria is essentially broken up into essential criteria that without which you will not get designation, and then desired criteria. And they cover every aspect that you can think of for obstetric anesthesia care, including personnel and staffing, equipment and policies, cesarean delivery, vaginal delivery, management strategies, recommendations and guidelines, as well as quality assurance and follow-up. So it's a fairly comprehensive look at obstetric anesthesia provision.
Yeah, it is a very comprehensive program. Kudos to you and the folks who've developed this. Now, as you and I know, we do not have patients just delivering and giving birth in large academic centers. We have people delivering all throughout this state and this country. What can anesthesiologists that are working in more rural settings, in those small community hospitals in California, do to contribute to programs like the SOAP Centers of Excellence, or to contribute to efforts to reduce maternal morbidity?
Yeah, so the advice I would first give is join SOAP. There's a wealth of opportunities and information you can get from SOAP, either attending the meetings or just going online to look at resources. As I mentioned, go to the SOAP Center of Excellence, download the application form, and see what criteria you can use to improve your own care that you can provide. Given the limitations of your setting, there will be many that you won't be able to attain, but certainly it's worth having that as a blueprint for what would constitute optimal care. I would also advise you to reach out to your level 3 and 4 centers. The whole idea behind ACOG was for the 3-4 centers to pull up the 1-2 centers, and raising the base is critical to that. So developing connections, consultations with providers in those centers can certainly help improve your care and risk stratification for your patients and who to refer and beyond all of that. And then the last thing I would suggest is, I think it's important that SOAP does recognize excellence in level 1 and 2 centers. So an initiative that we will move towards is getting a designation that is appropriate for each level of care. SOAP Centers of Excellence is clearly aimed at level 4 and possibly level 3. and a separate designation will be required for level 1 and 2, at least a minimum standard document with some designation and recognition for those centers that attain that.
Wonderful. So other than this perhaps new designation that'll be more factor in the ACOG levels of care for these different centers, what else does the future hold for SOAP's Center of Excellence? Where do we see this going in the next 10 years or more?
Well, as you mentioned, this was founded in 2017-18 while I was SOAP president. This was an initiative that I started, and I've chaired the subcommittee that has run this since. But it's also time for me to hand this over and let SOAP run with it, and very capable individuals lead this effort. So a lot of the future will be determined by SOAP and the subcommittee, with me cheering from the grandstands. I'll say this, I'm extremely optimistic. SOAP Centers of Excellence has exceeded my expectations several fold. So number one, the interest in it has been remarkable, not only nationally, but internationally. There's 83 centers that have received this designation, 72 in the US and 11 outside. There are academic centers, private community centers that have qualified. There are small centers with less than 1,000 and large centers with 15,000 deliveries that have qualified for this designation. So it shows me that, which the hope was that it wouldn't be an elitist designation for a few top centers in the country, but that many places could actually get this designation. And something that's not really well appreciated, that we see the centers that get this recognition, but there are many centers that have taken this document and used as a blueprint to improve their care. And obviously I hear about this as chair of SOAP Centers of Excellence. So it is improving care without necessarily getting the designation. And to me, that was something that I never anticipated would actually happen. For the future, I hope we can get very clear alignment with ACOG. And yes, rewarding level 4 with SOAP Centers of Excellence and changing the definitions used by ACOG to include this would be one aspect, but definitely creating clear definitions and SOAP Center of Excellence adaptions for level 1 and 2 would be very, very important. And I hope that eventually, as this becomes more widespread, patients use this to make decisions about where they deliver. So not just choosing the obstetrician, but choosing the center that can handle complications and emergencies that may occur, or that they will centers that will provide excellence in obstetric care. So and this will require, obviously, marketing on a SOAP side to start making this widely acknowledged and understood. And then lastly, I hope we get more growth internationally so that SOAP and Centers of Excellence can actually start improving care around the world. And this is something that I hope the future brings to SOAP Centers of Excellence, and we go beyond the 11 centers outside the US that have qualified.
I share your optimism and excitement to see where this project is going to go, and thank you again for your hard work in instituting this. And as you're preparing to turn this over to the future leaders of SOAP and our subspecialty, I hope we have a lot of listeners out there in medical school, residency, or even some very early career anesthesiologists. And what, as we finish up here, what advice are you going to give to those next generation of physician anesthesiologists that are going to be caring for the mothers in the future?
Well, to the listeners who are still in medical school, haven't chosen their residency, I think anesthesiology is an incredible specialty. I think a lot of what makes it amazing is that there's such variety in what you can subspecialize in and do. It's also obviously a lifestyle friendly financially rewarding subspecialty. I think the subspecialty of obstetric anesthesia is special. So to the residents out there who are trying to decide whether or not to do a fellowship or not, I truly think that my decision to do obstetric anesthesiology was the best decision I ever made. I think the reasoning is essentially because making an impact in our careers and our lives is very important to me, and we certainly make an impact in this subspecialty. We mentioned the maternal mortality and morbidity problem in the US, and being part of the solution is very, very encouraging. I love the fact that you take pain from 10 to 0 as rather than just mitigating post-operative pain like you do in most other aspects of anesthesiology, and that we are specifically trained to deal with the complications that we see in obstetrics like hemorrhage and cardiovascular instability. The ability to go beyond anesthesia as perioperative physicians, by definition, that's what we are in the obstetric anesthesia suite, helping manage a lot of the problems that were to develop. And to me, that's exactly why I want to be an anesthesiologist, not just provide anesthesia. And then two things that sort of make things unique for an obstetric anesthesiologist is you're affecting two lives. You don't just have one patient. You have a birthing person and a either newborn or soon to be newborn whose lives you can impact with the care that you provide. And we are around at a time that's probably the most important day in parents' lives, and we're there to witness this, and it's a happy time. None of us want to have our hip replacement surgery, but the patients we deal with in obstetric anesthesiologists are there because they want to, and they have an exciting life ahead of them. So being witness to that just makes the job extra special.
You're so right. It's such a privilege to be there with the birth of a new family. It is a very rewarding subspecialty. So before we finish off, I'm going to end with some rapid fire questions, something I like to call code anesthesia. And Brendan, I just want your gut instinct on these, okay? No thinking about it. No, you can't have both. You can only choose one. So you get two options. You can only choose one. And I created this questions based a little bit on your clinical and professional interests, so nothing too challenging here. So you just let me know which one you would choose. And I think I know the answer to many of these, so I'm intrigued. Regional versus obstetric anesthesia.
Obstetrics. I love both, but my nod is towards obstetrics. But I'm also do regional anesthesia, and I think it's a fantastic subspecialty.
Wonderful. Epidural versus CSE.
CSE.
Ropivacaine versus bupivacaine for labor analgesia.
Bupivacaine.
Great. And for your choice of needles for cesarean spinals, Whitaker versus Sprott.
I'm just happy to have a needle with the current crisis.
Really good point. I know. Some days you really cannot be too much of a choice here. Yeah, I'll give you that one.
I think the key is that you use a pencil point, 25 gauge or smaller. Probably doesn't make a difference with the manufacturer, whatever you're comfortable with and whatever's in your kit.
Great. Well, along the same lines, are you a plastic or a glass loss of resistance syringe person?
Oh, plastic. And please, continuous, and put saline in it, no air.
Everybody has opinions around that one. And I think, it'll be pretty obvious, but spinal versus general anesthesia for cesarean?
Yeah, clearly spinal or combined spinal epidural for sure.
Great. And lastly, the same one we give everyone, Miller versus McIntosh.
Well, when I occasionally have to do general anesthesia, it's McIntosh. But my wife's a pediatric anesthesiologist, and for her, it's Miller all the way.
Yeah, family controversy there. All right. Well, thank you, Brendan. This concludes another episode of Vital Times, the podcast. I'm Ron George. I would like to thank Dr. Brendan Carvalho for being such an incredible guest and sharing his insight and knowledge around the SOAPS Center of Excellence. And I would implore everyone to check out the link that'll be in our notes and visit the Society of Obstetric Anesthesia and Perinatology website to learn more about the Centers of Excellence and start your preparations for maybe looking into getting that designation of a Center of Excellence next year. And lastly, I want to thank all of you for listening. It's been a pleasure. Take care.